Morning, Dr. Foteh. Thank you for joining us here to discuss Rotarex. Glad we were able to find some time to meet. Before we get started, I'd love for you to introduce yourself and tell us a little bit about your practice.
Well, thank you for having me discuss Rotarex today. My name is Kousta Foteh. I'm a vascular surgeon. I am a physician in a private practice, fully a private-owned multi-specialty practice that includes over 30 cardiologists. We now have four vascular surgeons. We just hired our fifth, as well as as well as three endocrinologists. We have our own OBL and ASC that we operate out of and do several cases from. I've been a practicing vascular surgeon for, I think, 15 years now, and really passionate about peripheral intervention and particularly limb salvage and pedal access. And look forward to joining y'all today.
Can you talk about how long you've been using Rotarex and how your usage has evolved over time?
Think just a little bit over a couple of years. Initially, the usage was slow. I'll admit that I was a big user of orbital atherectomy for a long time. Again, this was before even Rotarex had come into the U.S. market. Um, it was slow, but it grew exponentially. And I say that because I consistently got really good results with the early usage that I had, which led to my growing interest in using Rotarex for more and more of my patients, and it's just grown from there.
So you mentioned that you were using Orbital previously. What was kind of the catalyst for the transition to Rotarex?
Honestly, it was the introduction of IVUS into every case. I think for a long time, I never really used IVUS for anything, and then as it became more of a routine part of my practice, I started to notice, the lesions that I was treating um, were not exactly ideal for orbital atherectomy. Um, Before I would take a picture, it looked like there was calcium there, and my default device was the orbital atherectomy device. But with IVUS, giving you more of an idea of what the morphology of the plaque is, it allows you to make better decisions, and it allows you to, I think, keep the patient safer because you're using the correct device for the lesion that you see at hand. So really, IVUS has a lot of credit for me transitioning over into Rotarex because what I've realized is the majority of my patients have a lot of mixed plaque etiology, soft fibrothrombotic, mixed with very mild calcium, and that's just something that orbital atherectomy can't tackle.
Can you just elaborate a little bit more on your selection criteria for Rotarex? So you mentioned that IVUS has played a big role in that, but is there really a signal that you see either on angio or IVUS that you know is going to be a good case for Rotarex?
Yeah, so a couple things. On IVUS, if when you look at the plaque morphology, I look for, soft. I looked for soft, what I consider soft fibrotic plaque or thrombotic plaque, mixed plaque. If you see just some mild calcium in the periphery of your IVUS image, and but on more of the interior of the vessel, you're going to get fibrothrombotic plaque. Uh, then, in my opinion, orbital atherectomy is not going to do anything for you there. That's where Rotarex really becomes very helpful and useful in that situation. Also, when you take pictures with diagnostic angiography, if your wire easily passes through a lesion without very much manipulation, you're going to have a pretty good idea that this is probably soft stuff you're dealing with, whether it's clot, thrombus, or fibrous or fibrous plaque. That's probably going to be something that Rotarex is going to use. So those are really the two things that I look for. Um, and also, when you do a diagnostic angiogram, sometimes when you take a picture and you see a lesion, an occlusion, if it looks acute and there's not really a lot of calcium you see under fluoroscopy, that there will cue you in. This is probably going to be a very good Rotarex case.
How does the aspiration component of Rotarex separate it from other devices in this space?
It allows for thrombectomy and atherectomy. Uh, with the removal of the disease inside the vessel wall.
Earlier, you mentioned pedal access. So, can you talk to me a little bit about your experience using Rotarex from a retrograde access?
Yeah, so just full disclosure, I would probably say that about 80 to 90% of my cases are primary pedal access. And so I have used Rotarex from uh, the pedal retrograde approach multiple times. And I've run across no issues. It works very well. There's a couple of things you have to keep in mind. You need to know what your access is like when you do pedal access. If you have really diseased or terrible tibial arteries, you probably shouldn't be advancing a Rotarex device through that tibial vessel. Now, there are things you can do to maybe help assist the passage of a Rotarex device. If the tibials look diseased or small, you can do balloon angioplasty and see if that'll help facilitate the ease of passage of that device. But coming from below really is very easy and very efficient, in my opinion, and it works just as well as coming from above. I've had no issues, and I think it's actually a great way to treat diseases from below. Um, uh, and being able to use the device is great from a fetal approach.
Can you talk a little bit about what it was like for your staff to transition to Rotarex?
The only learning curve that we had was just setting up the device sterilely. As you know, there is a suction bag that comes off to the side. You've got to drape the handle or the gun so it's sterile. Uh, but overall, there wasn't much of a learning curve. It's very easy to figure out. It's very intuitive. And plus, the reps are in the room to help facilitate any questions or help us troubleshoot. So really, it was a very easy transition, and there was not a very big learning curve. Um, they know how to prep it. They know to flush it before use. Know how to load it onto the wire correctly, and we've had no issues. Very easy transition.
What would you tell a physician that has not yet adopted Rotarex to their algorithm?
Well, I'd like to know what their algorithm is first before I talk to them about it. You have so many different opinions on peripheral intervention. It's really hard, to tell someone, hey, here's what you do. But let me just tell you how I approach it, and that's maybe how I would bring it to the attention of other physicians. For one, I really believe that we should be using IVUS for every peripheral case. IVUS gives us a lot of valuable information that we can't see with our own naked eye. It allows us to know the composition of the plaque that we're dealing with. It gives us the appropriate size of the blood vessels. It tells us we are intraluminal, or if we're extraluminal or subintimal. So those are very important pieces of information to know. And I would say in the old days, we kept hearing a lot about calcium and how a lot of times calcium is underdiagnosed and we don't appreciate the full extent of calcium. But I can tell you, what I'm seeing more and more on IVUS is mostly mixed density lesions, meaning that there is some calcium on the outer periphery of the lesion, but it's more soft, fibrous, thrombotic plaque buildup in the middle, and that's where you need to do your work. So I would recommend physicians that when they cross a lesion, to don't just take their angiogram at its base value. Use the IVUS, see what the actual makeup of the plaque is, and if it's this soft mixed etiology, you're not going to go very far using orbital atherectomy or directional atherectomy. I think directional atherectomy is a very inferior device. I don't believe in the laser because I don't believe in their technology. I have not used it in that situation, and I would consider using the Rotarex. So I would say I use Rotarex probably 80% of the time now, just because of and that's simply because of what I see on IVUS that the other devices cannot treat.
Lastly, can you tell me about your favorite case?
I think my favorite case it was a limb salvage case. This is a situation where a patient came in with a wound that was not healing. The ultrasound showed evidence of tibial disease as well as infrapopliteal and SFA disease. It appeared to be occluded. We were able to gain access into the posterior tibial artery. We did a retrograde angiogram, and it appeared that the mid posterior tibial artery was occluded. and the anterior tibial artery and the mid distal section was occluded. So the first thing we did was we crossed the occlusion of the posterior tibial artery. We then uh, used a Highlander balloon to do primary angioplasty of the posterior tib. We then went up and over the TP trunk and guided our wire down into the posterior tibial artery, and then used another Highlander balloon to balloon that and got a great three vessel runoff result. And then we guided our catheter into the bony popliteal artery. We did a retrograde angiogram, which showed that the distal SFA proximal popliteal artery was occluded. We were able to cross retrograde, and we got into just the proximal tip of the SFA. We were then able to use IVUS, and IVUS confirmed the size of the blood vessel, that we were intraluminal the entire way. It also gave us an idea of the mixed plaque morphology, which I thought was perfect for Rotarex. We used a 3 Highlander balloon in the tibial, so we know we had a good sized tibial vessel to advance the Rotarex catheter. We did several slow passes of the Rotarex. I would probably say a good 3 or 4 times, with just that slow 2 steps forward, 1 step back movement. We then advanced the catheter and took an angiogram, and it appeared as almost, the entire lesion was gone, and it almost looked like a normal SMA. Of course, we did balloon angioplasty afterwards, got a great result, showed no dissection, 3 vessel runoff, palpable pulses at the end of the case, and the wound healed up in the matter of a couple of weeks. So I thought that was very gratifying, and being able to go pedal and treat 3 blood vessels from a single, pedal access to get limb salvage, to me, is always gratifying, and that stands out as one of my favorite cases.
Wow, that's sounds like a phenomenal case. Thank you for sharing.
You bet.
We we appreciate your time here today. Thank you for talking about your experience, and we look forward to talking with you again soon.
Thank you so much, Caitlin. I appreciate it.